Welcome, everyone. It's 10 o'clock. We've got this great panel who's going to be discussing the COVID-19 details. What are the facts, what's the fiction, and what's really going on. And our panel includes Paulette Altmaier and Mike Rodgers, who Wendy will be introducing. But as we do, we always have a few little announcements to make. Very quickly, we always thank our sponsors and our members because they make these meetings possible. All our online meetings are free, so invite your friends. If you're new, I should introduce myself. I'm Jan Soule, and I'm the president of SVARW. So invite your friends. Our next meeting, it's our regular SVARW meeting. It's Wednesday, July 22nd, and it's going to be on the U.S. Constitution versus the COVID-19 lockdowns. How do we fight back? Our speaker is Timothy Snowball. He's an attorney for the Pacific Legal Foundation, and you can register for this program on our website. Wanted to make sure everybody knew Republicans are gathering together over the summer, and we have hey, there's an election coming up in November. Anybody know about that? Both, not only on the national level, but we need to elect, we need to flip at least 7 congressional seats in California to help President Trump in his second term. And we have many local candidates running that we need to help. So there are these parties for Republicans, and there's 2 on July 11th, and that is tomorrow. So go to our website. There's a list of the parties, and there's a list of how to send an RSVP to the parties. In fact, Mike Rodgers is hosting one of those parties, right? On the 15th. No, on the 25th.
Yep, a big barbecue.
Because Jan Soule and Peter Soule are hosting the one on August 15th. So please come. These are great Republican gatherings. That we already had one, which was a hoedown in Gilroy, if you were there, and a good number of our Vietnamese friends were there, and we appreciate that. Okay, so I am now turning the meeting over to Wendy Brukwinski. Wave, Wendy. Wendy is our VP of programs and the person putting all these together, and she's going to be introducing our panelists, and so that we can get started.
And good morning. And as always, we're going to be taking questions for the speakers via the Q&A or the chat, whichever you prefer. Questioning today is going to be handled by myself, along with 2 board members, Mingy Bodine and Lisa Sego. And getting right down to our program here, Mike Rodgers, who's a featured speaker today, spent 20 years at Intel, developing and building new technologies and organizations, and he's a great guru with numbers and statistics and whatnot. Currently, he's the Vice President of Engineering and Product Development at i360 Healthcare. He has decades of experience, which we love, working with conservative causes in overwhelmingly blue districts in Chicago and New England, and now he's going to bring his magic to our area. He's an avid tennis player. Before he moved to San Jose, he was the president of the 50-year-old Mountain View Tennis Club, which he incorporated as a nonprofit, and he helped start NetGain, which is an after-school tennis program for less affluent kids and people on different areas in town, where he still coaches, apparently, performance juniors and teams. And Mike was elected, this is exciting for us, to the Silicon Valley GOP Central Committee this last March in the election, and he'll start in January as a representative for us. Paulette Altmaier is our local hero. Instead of just complaining like I do, a bunch of us do. She actually puts her money where her mouth is, which we love. She's placed 2 open letter ads, which you've probably seen. They're full page ads on the back page of the Mercury News, where she's addressed these letters to the Santa Clara County Health Officer, Sarah Cody, and to our Board of Supervisors, telling them, come on, let's get moving here. What are the plans? What are you going to do? Are you just going to let our entire economy and all of our citizens languish in abject fear, or what are we going to do here? Paulette is a senior technology executive, and she did a stint at Intel too, as I understand. A very interesting place to have come up through. My sister was there along with them. It sounded like a lot of fun. Now she's responsible for billion-dollar high-tech businesses in leading Silicon Valley companies, and she serves on the boards of several technology-focused nonprofits and is an advisor to high-tech startups. She immigrated to the US shortly after earning her engineering degree in India. Her husband's also an engineer and grew up as an Iowa farm kid. They have 2 daughters. And now I would like to introduce Paulette. Take it away, Paulette.
Thank you, Wendy. So as Wendy mentioned, the reason I got involved with the pandemic response is that our policy response to COVID is doing an enormous amount of unnecessary damage. So since the beginning of the pandemic, we've heard officials proclaim constantly that they would be guided by the data and the science. But California's and Santa Clara County's policy has been guided primarily by panic, as far as we can tell, and it's often been contrary to the data and to the science. If you look at the guidance, the epidemic guidance for epidemic management policy from the CDC, from WHO, from all the agencies, it has always been that putting entire populations of healthy people under quarantine, as well as shutting down society and shutting down the economy, was counterproductive, and that more tailored methods should be used. That's been the guidance forever. But when COVID hit, the healthcare systems in Wuhan and then in parts of Italy got overwhelmed. And so they panicked and they locked down. So in California and in our county, we were never remotely close to overwhelming our healthcare systems. But for some reason, Santa Clara County panicked also and locked down. And very shortly after, California locked down. And most of the country, mercifully not all, did the same. One could say we knew very little at that time. This was all new. Everyone was uncertain what was going on. But at this point, we know so much more, and we have known a whole lot more since mid-April at the very minimum. We know who is at risk. We know very importantly who is not at risk, which Michael will talk about later. And yet California and, much more so our county are still operating basically from a place of panic. For instance, we were told in mid-March that the shutdown was to flatten the curve, to prevent our hospital systems from being overwhelmed. We were told that over and over, and it made total sense given how little we knew then. But California has forgotten about flattening the curve, and we see partial shutdowns being reinstituted when less than 10% of California hospital beds are currently occupied by people who have COVID. And meanwhile, our own county is in a much more troubling place. Our health officer, Sarah Cody, and our county exec, Jeff Smith, have basically abandoned this whole concept of flattening the curve. And they are very explicitly saying that they are going to control our lives forever, or indefinitely, perhaps is a better term. So we hear ridiculous statements from them about reopening, like we don't have herd immunity, as if you can get herd immunity while sitting in your house. And we don't have a vaccine, but vaccines can take years or to develop safely. So while all of this is going on, all the panics and the shutdowns and the lack of adherence to prior well-known protocols, what we see is that the economy is being crushed, and it's the economically vulnerable who are suffering the most. Our valley has a lot of professionals and government bureaucrats who are comfortably working from home and who are being fully paid. But the service workers and the poor are bearing the brunt of this, of the needless panic that we are engaged in. For instance, in California, I'm sure you've heard Newsom talk about these numbers. Our current unemployment is 16%, and it's a very unequal impact. It's the poor who are suffering. Nationally, I don't know the exact number for California, but nationally, 40% of those making less than $40,000, 40% of those workers have lost their jobs. Black and Latino populations are hit the hardest, but their voices are not being heard. Only the comfortable class is being heard from, especially in our county with its preponderance of tech workers. And that brings us to the issue of health officer powers, because we've had to, sort of try our best to get heard at the county level, but we find that we come up against the wall of health officer powers. None of us knew about this problem before, but it's a critical issue that we are all aware of now, and going forward, we need to address. The California bill that gave the health officers these extraordinary powers is AB 262. And very briefly, it authorized the health officer to take, quote unquote, any action necessary to control the spread of communicable disease. But that's being very broadly interpreted in our county, and some other counties not so broadly, where the supervisors are more clearly in control. But here, we see that our supervisors have basically been content to let Sarah Cody ride roughshod over them and everyone else, and literally operate as a dictator, controlling every aspect of our lives. Now, AB 262 is very broad and is very vague. Its current interpretation has never been tested in court. A similar law in Ohio was recently struck down by the Ohio State Supreme Court as violating the separation of powers, basically giving an unelected official dictatorial control. So in California, it's never been tested. This is something we need to address sooner rather than later. And I'll come back to that when we talk about what some of our future priorities need to be. And then if we look at the media, what we see is total irresponsibility. Their preferred narrative is just fear-mongering. Every possible random negative anecdote is magnified and hyped, with no context. And what we see is, frankly, is that half the population is afraid of their own shadow. The fact that a very large majority of the population is hardly at risk at all, especially people under 45, that's never reported on. Children are at far lower risk than from the flu. And unlike the flu, it's been proven that they are not spreaders. That's never mentioned. So what we get instead is, I guess you can only call this panic porn, is the phrase I've heard, and I think is very apropos. And finally, if we look at the scientific community, and this is the most troubling of all, the scientific community has also failed us. They have abandoned, one would have to say they've abandoned the normal scientific method and have become willing participants in propagating a very politicized fear-mongering narrative. Our local Nobel laureate, Michael Levitz at Stanford, has spoken out very strongly about this. And it's really interesting. He gets no publicity and no press, even locally, although he's right here. His research studying actual data does not conform to the popular panic narrative. He, in fact, called out the problems with this infamous imperial model on the basis of which the UK and the US closed down. He called out the problems before we locked down. And he pointed out there was no scientific consensus that lockdowns were the right approach. And he said there was no scientific discussion at all. The governments just looked at a couple of now highly discredited models and then they shut down. And that approach seems to be persisting, far beyond what the data tells us. So, and even now, when findings contrary to the fear narrative are presented, instead of rebutting with data, as science is usually conducted, if you have data to rebut, Michael Level points out that scientists contact him and tell him, stop talking about it. This is not the way science is conducted. Similarly, John Ioannidis at Stanford, he's an epidemiologist whose research is among the most widely cited in the world, is under heavy attack for pointing out that there was no evidence lockdowns were the best strategy. And now he's under attack again for pointing out that for most age groups, COVID has extremely low mortality. So to summarize, the actual facts are contrary to the narrative in the media. So it's really important that people become aware of the real situation and the real risks. Our politicians have succumbed to panic. The media is not educating us. So we have to accomplish it, as citizens, with forums like this one, and, learn what's really true, because we're not going to learn it from the media. So Mike, you have a lot of hard data on COVID and on the real situation. And I know that's what you're planning to present today.
Okay, I'm turning on my screen share here and we'll start the presentation mode.
Going down.
So can everybody hear me okay?
Yep. You
And
can find.
my slides are up. I'm going to go through an agenda here. Any one of these bullets could be an entire hour-long talk. So I'll have a lot more data on my slides than I actually have time to cover. And I'll try and cover the most important points and give you a different narrative than what you get from the mainstream media, which Paulette described so accurately. And I can think of 3 or 4 or 5 different studies about how the lockdown that show scientifically, either by measuring how the lockdowns are not the most effective way to deal with this, but I'm really focusing on where we're at and where we need to go, because that's where we're going to wind up here at the end, right before we start a lengthy question and answer sessions. First, let's talk about the disease, the physical disease itself a little bit. The big challenge has been it's much more contagious than the original SARS because of the way the virus is physically constructed. And one of the things that makes it much worse for humans is if you have a range of diseases, and I like the description best of Dr. Robert Lustig from UCSF, who's professor emeritus now, but used to run their childhood obesity program. The range of things that people are now calling metabolic syndrome, which have associated diseases of kidney disease, non-fatty liver disease, all characterized by strong insulin resistance driven by what's going on with people's diet, diabetics, pre-diabetics, obesity in particular, have more ACE2 receptors for the virus to attach to. So they not only get the disease easier, but they tend to have the stronger, what we've heard about is the comorbidities. They tend to have the stronger cases and the larger risks, and the vast majority of the deaths is increasing with age by a strong correlative factor as well. So compared to what we were being told a few months ago about all these things of it's a droplet like tuberculosis, you got to worry about surfaces and stuff. The most riskiest thing is really groups of people indoors, especially without the use of masks, which we now know are much more important, contrary to what the CDC and the World Health Organization were telling us, giving us wrong information for months about. Masks are incredibly important, as we saw in the Asian communities that did really well, that sit right next to China and have some of the best responses in the entire world. Universally, when you talk to people there, they say masks were such a critical factor. They're on top of the fact that they were doing track trace and other things earlier and had tests running faster than we did here in the US. But a couple of things about the disease that are important to know. Surfaces are much lower risk, and outdoors is much lower risk, possibly as much as 10x to 100x or higher. And again, groups inside, especially dense groups, but over periods of time. So if you're in a group of 10 people for 5 minutes, it's not anything like being in a group of 10 people on a bus for 3 hours breathing the same air, because you're not going to get sick from just getting 1 or 2 copies of the virus. There's a dosage issue involved. And the fact that you're in an enclosed space with a lot of people over a long period of time means that a higher percentage of people in that situation will ultimately become infected. Okay? So I want to go back to and talk about something, and I'm going to use some words Paulette and I gave me the idea of how to describe this: rebalancing people's sense of risk. We're so characterized by the, I would call it the death scare porn of the mainstream media. The real reality, the infected mortality rate, which is different than the number of measured sick people that eventually die, but the true population of people that actually have the disease and end up having mortalities because they're in this tail of people that have different obesity and diabetic concerns or related concerns is less than 0.25%. And when you talk about flu, that's about 2 or 3 times as much as flu. Flu runs, it changes by year to year. We have more severe years, less severe years. But in general, it's about 0.1% of the population. And to talk about kids a little more, because parents are worried about, we have school coming up, pediatrics susceptibility and their, even when infected, the severity of cases extremely, extremely small, hard to measure, much, much less than flu, much, much less than 0.1%. Whereas in some flu varieties, such as the variety of influenza B, Victoria, that we had in the early part of the flu season last year, it was abnormally high incidence of severe form hospitalizations and mortalities with children, much higher than 0.1%. So to give you context here, talking about COVID versus flu, we see there's a tail of people with certain comorbidities that are really at risk, but the rest of the population is going to have low severity rates, right? And we look at across the history of pandemics, and we modulate how many people died of these major pandemics over the last 100 years by the amount of population we had at that point in time, we can see that we're not even to the point yet where COVID-19 is greater than 1969, the Hong Kong flu, where we didn't shut down the economy, or the Asian flu, which had the equivalent of 250,000 people died, right, when we had a much smaller population. 1969, we had Woodstock going on, and people didn't end up, 100,000 people come home from Woodstock end up being sick and dying. So it gives you perspective on what the real things that are going on with the disease and what the real risks are for a small part of the population. Let's talk very briefly. I talked about masks a little bit, effective mitigation strategies. So we've used lockdowns. We've totally cratered the economy. And in the first time in the history of the United States, or pandemics in general, we quarantined healthy people. Right? We never did that in any other pandemic in U.S. history. So we're past the point where we need that sledgehammer. We don't have any place in the U.S. with 70% tested positive rate. The highest places are in the 20s and a few pockets. Arizona's at 30%. The overall state of the country is we should be tactically looking at how do we protect the people most at risk. And the best way of doing this, it becomes less of government intervention, a Marxist dictatorship approach, and it really becomes more of a Republican value of personal responsibility. How well do we maintain our hygiene? How well do we manage groups and masks indoors? And we don't need to be 100% compliant. The vice president of Taiwan, who is a U.S.-trained, multi-degreed epidemiologist, Taiwan did as well as anybody in the world, and he says, look, it's personal protection gear for your healthcare workers, and it's personal behavior of people and wearing masks. And 75%, if you do the statistics, 75% of people complying means that you're killing more, the virus is not propagating, and the disease is going to be going down to a much lower level. So the other point is we should be doing more of the stuff down towards the bottom, which is we have better therapeutics today, and they're coming online, and we have the ability, now that the disease is in a manageable states, to chase down the outbreaks and the classes of things that we miss. So we know now long-term healthcare facilities for the elderly were a problem, and we've dealt with that across the country very effectively. But it's not widely known that agriculture is another thing that's showing up as a major risk area, and where some of our pockets are very active here locally in the Bay Area as well as in California. I'll talk about that a little more. So I wanted to get this concept off about lockdowns and changing the area of the curve. Lockdowns, we cratered the entire economy to the impact of trillions and trillions of dollars. We went from plus 2.5% to 3% growth GDP per year, which we hadn't been at since the original Great Recession, to now we have probably a negative 5 to 10% range GDP going on per quarter. We have to get the economy going because it affects people's lives in many other ways. But we did flatten the curve. By the end of April and early May, all of the major local epidemics across the U.S. had flattened the curve. But the reality is, hammering the economy did nothing but flatten the curve, didn't change the area under the curve. We have to do something different to mitigate the area under the curve, which means the number of people that get sick and the number of people that go to ICU and lower the death rates. So this is a graph from the IHME model, which is probably in the U.S. the most widely used model. It was originally just curve fitting, and then later they added behavioral characteristics as they started to realize that the back end of the model was not very predictive. There's actually 3 different scenarios here, and it makes my point. At the very top is the death rate, modulating with, we're not doing anything, to modulating by, we're relaxing more of the lockdown stuff. And you can see that those 2 lines, the blue and the red line at the top, are almost on top of each other because lockdowns are no longer really effective because of where we're at with the virus today. And the green line is actually if we get to the point where we have a sufficient percentage of mask usage going on across a lot of the areas of the U.S. where they aren't today, or across California where we've gone from 0 to 5% in many areas to maybe 30 or 40% in much of California outside of the Bay Area. We need to get mask conformance higher, and we'll be able to see that we actually can change the area under the curve. This is another way of looking at it. If we look at Dr. Burks here giving us an example of how you ought to wear a mask correctly, but if we look at the daily death rates, now you can see we not only, we're not taking a sliver of the area of the curve off, we're hammering it. down to a lower level that we don't have to keep everything closed down just by behaving, right? The converse side of this is where mask conformance was really bad was in all the summer vacation spots along the Gulf Coast, South Carolina. We had a lot of young people coming down from other parts of the country and really congregating. And when I say young, I'm not talking about pediatrics, I'm talking about young adults, packing the bars as things started to open up in Phoenix and Scottsdale in Arizona and Houston in Texas and in South Florida, South Carolina along the coast and stuff. That's where we're seeing exploding numbers of cases. So the flip side is use of masks modulates how well you continue to do against the virus in the short term. Again, here, when you look at cases per day, we can see, okay, we throw the easing lockdowns in there again. It doesn't make that big of a difference versus personal behavior. The lockdowns are not as effective at this point in time in the epidemic. So I want to go on and keep moving here. I'm going to not describe all the data points here, but I want to give you two concepts is how healthy are we doing in the Bay Area? The Bay Area, Santa Clara County as a metropolitan area did as well as any metropolitan area in the U.S. against the virus. We had the earliest known community transmission, the earliest known deaths, the earliest clusters in the U.S., and yet we got to a tested positive rate that was far ahead of anything else in the country by the beginning of May. We were down to 2%. And below, we were even very close to 1% tested positive rate. Now, the second concept is the most important parameter we have available today is the tested positive rate of how many people get tested that day in a given county, given city, et cetera. And we're actually using that locally here in Santa Clara County, where we're looking at Gilroy and East San Jose in particular. I'm sure that in Monterey County, where they're starting to get their hands around some issues that they were having among agricultural workers, and Salinas are looking at that locally because Salinas is much different than Monterey. So we have two different epidemics, even in the concept of the same county. And we see that in Marin, where we have San Quentin is obviously a big snafu and is now spilling over into, because you have a lot of the local workers there, spilling over to Marin, and it has additional impacts that we have hospitalizations that are distributing out of San Quentin across most of the counties in the Bay Area and other parts of California, even some being sent out of state. But overall, the second most important parameter is what is your true hospital capacity, because when you start to get full, over 2/3% capacity of regular beds, and more importantly on ICU beds, then your system starts to become overwhelmed. And we can see that nowhere in the Bay Area is that really true, with the exception of Napa County, where they only have 9 beds of ICU capacity, and they got 8 people in them. Either from the agricultural workers that live in Solano County that work in Napa, or they've gotten some of the patient overflows out of San Quentin. But in general, this does not reflect the state's map, which is showing counties in this range going on and off the watch list, because the state's metrics are moving to variance and allowing counties to make decisions to open up further are somewhat broken. They were okay for the point in time when we started this 2 months ago. They had added the test positive rate as a key metric about 2 months ago, but they haven't made any changes to them, and their metrics really don't map to where we are with individual epidemics and as a state and as a country. It's disrupting businesses here that open and close, and the counties that open and close. We should be focusing on chasing down the tails of the epidemic locally, because we're doing very well here in the Bay Area. Now, the Bay Area is much different than the rest of California. Our use of masks here was very high. We had a bunch of freaked out knowledge workers. We have a lot of Asians who are very familiar with doing this, a longer history culturally. Santa Clara County, I go around and I work and I'm out on the road a lot. Mask use is pretty ubiquitous here. It's not 100%. But as you get to other parts of the Bay Area and other parts of California, and I talk to people all the time about this stuff, the reports were widely different. Outside the Bay Area, mask use was very little, right? Sacramento, I get somebody posts on Facebook, why am I the only one wearing a mask? I get these reports from all over the state. It's changing. Governor Newsom made an order about a month ago requiring it in public, but it's not where it needs to be. It's still like 30 to 50% in places like even Sacramento, Central Valley. And in Southern California, you had the health officer in Orange County quit in frustration because of the threats she was getting when she tried to make a mask order. And we can see that the statistics and the test positive rates across Southern California, really, to tell you the true story, we do have major problems in the urban areas of Southern California in particular. But another secondary problem is the agricultural workers. I mentioned Salinas and Gilroy and what was the other? Solano County workers that actually work in Napa show up. But when you look at the high agriculture areas of the counties throughout the Central Valley, we're seeing these numbers have changed dramatically just in the last 2 or 3 weeks. So I don't know if that's just the agricultural workers, but it's been changing rapidly in recent weeks. And we see a number of counties in the north end of the valley just starting to get flagged. But again, I forget, I think that's Yolo County up there that's actually green. And it actually, in terms of the test positive rate, but it gets flagged because the county metrics are based on total number of cases per 100,000 over a 2-week period, which is not independent of the number of tests. In Santa Clara, we got dinged for both hospitalization and cases. And we went from testing 1,500 cases a day in the middle of May to now we're doing over 6,000 cases a day. If I get to 7,000 cases a day in Santa Clara County and I'm at the same tested positive rate, we'll be flagged again, and all the nail shops will be forced to shut down again until the county convinces the state that we're actually healthy. One thing we haven't done well here as a county is negotiate with the state, because the state has been very flexible in general on the requirements. Getting on the watch list is supposed to be, let's have a discussion about it. But more recently, because parts of California really are having significant issues, it's getting harder to get past that, and the state really needs to fix their metrics. A comparison here, Northern California versus Orange County, there are about 33% more people than us, and the much different picture of what's going on with COVID there. And you can see that, and then their hospitalizations are 10 times as much as we have in Santa Clara County, in spite of the fact that Santa Clara County and San Francisco in particular are two of the places that some of the most severe patients are coming from other parts of the state. In Southern California and Imperial and Riverside counties, which are rural counties with extreme disease states or kind of really alarming disease states, we're getting patients every week coming from those parts of the state that don't have either the best ICU facilities or their patient counts are trying to keep the hospitals to have some capacity availability. So the state is trying to manage that now. It's not clear how well they're doing, because we're getting dinged when we go from 2% to 4% of overall capacity, because we went from 50 patients hospitalized in Santa Clara to 70 patients on June 23rd, and we didn't get that removed until just last weekend, right? That we finally negotiated with the state to say, look, you're sending us patients. Don't ding us for this. Let us come off the watch list. So this slide is very important. And this is the nut of what the decision-making process has been problematic at the county level, particularly here in Santa Clara, because we were the leader of all the original 6 counties, and which then became more counties and then the state. It's not life versus economy. All of the decisions related to what rules you make have life and economy on both sides of the decision. There are significant life and negative health outcomes for all aspects of everything you do to lock down. 20 million, significant negative health outcomes for 20 million people losing their health insurance because they're no longer full-time employment and they got insurance for their employment. There was a great study just in the last 48 hours about, just look at colon and breast cancer. There's how many thousands of additional deaths will there be because we even delayed the screening on that for months here. And there's many tens of thousands, probably just in our area alone, of cancer screenings that didn't occur over the last 3 months. This has negative health impacts on people's jobs, let alone talking about employment and losing your business. And the actuarial tables will tell you anyone over 40 that loses a full-time job, their mortality rate increases by 50 to 100% in the next 12 months. And it's got to be harder for small business owners, and then stress is itself as a total killer. And while the multi-dimensions of stress that you have because you're locked up, you lost your business, you lost your job, and you're under financial duress, they're horrendous. And we see this in terms of physical abuse cases increasing, 600% increases in local suicide cases, a higher rate of success in suicide cases across the local psychiatric ERs. So in all cases, life versus economy shouldn't be part of any part of the decision on what we're doing. We should be making the decisions to combat the disease in a tactical way where the disease has risks, which is not the entire population, not the entire economy at this point in time. The current criteria, the broken state of the metrics, I mentioned the cases per day, 100,000 per 14 days. The problem in how we're getting dinged here in the Bay Area for this one as well as the first one, which is the percent increase in COVID population in your hospital. So if you go in generally, you go from a raw number of 5 patients to 10 patients in, say, Napa County or San Benito County, because you didn't have a lot to begin with, you're going to get dinged because of the percent increase in patients, when in fact you went from 3% to 6% of your total hospital capacity, even if you don't have a lot of capacity. It really needs to be based on what's the percent of hospital capacity available, because that's what drives your ability. The risk is your system overwhelmed? And given the fact that we do need to be managing hospital capacity right now across the state because of the worst areas of the state, we shouldn't be spending our time with a control limit that's putting our focus in the wrong counties, in the wrong place, in the wrong time. So that said, I want to transition to what do we do moving forward. Therapeutics have a lot of opportunities here. I like the examples of Germany and Israel, who, as people were being tested positive, they did therapeutic follow-ups within 7 days to find out where were the patients that were starting to show advanced symptoms. We have widespread off-the-shelf available technologies today. You can buy a blood oximeter for tens of dollars. Anybody that tests positive, the county ought to be giving a blood oximeter so that they can identify anybody whose blood ox drops even into the mid-90s, not when they get to the hospital at 50%, you're already destined for the ICU and probably destined for a ventilator. Germany and Israel have some of the lowest mortality rates in Europe, in that part of the world. But we have more drugs coming online that will get here that already have the ability to modulate capabilities of disease. And the other thing that's greatly unleveraged, I mean, there are a lot of certain steroids actually very effective against the anti-immune, the cytokine storm that happens with your immune system. That is really how people get severity and death from COVID. And people are experimenting now or giving cocktails of different drugs in combination or in sequence, and that seems to be very effective. Getting the patients sooner, we've already changed the area under the curve. So the curves I showed you before, those curves are already changing, and the area under the curve is decreasing because we're getting better at treating the disease, which just means there's ever more reason that we should stop using lockdowns and be using targeted therapeutics and targeted risk areas as what we're focusing on. The other one is that we're not really utilizing well, since we've got a lot of people, there's anywhere between 10 times to 50 times as many people that were infected locally. People that test positive for antibody tests have the opportunity to donate plasma. That plasma can be a very effective treatment. If they're confirmed to have antibodies, you can treat 10 to 20 patients with those, which really do knock down the virus with a single contribution, a single donation. So that's an opportunity. Some people are starting to organize that now. We should be doing more of that. Vaccines, there's a timeliness of vaccines, has a lot of uncertainty. The efficacy is a lot of uncertain, but what the world is doing now, it's unprecedented, the amount of money and amount of work that's being done. And some of them, there are companies already building risk builds of some of the vaccines, but it still has an uncertain timeline. I think there's much more we can be doing now in the short term. Besides getting business going again, we can treat patients better and make better outcomes long before the viruses get here. And with that, I will put up the question and answer slide again, which has our emails on it, because we're welcome to you contact us. And I'll turn this back over to Paulette for a couple closing statements about where we're going.
Thanks, Mike. So, based on what Mike has said, we understand the risk issues a whole lot better and where things are therapeutically. But we have some very key issues that we have to deal with locally. The biggest upcoming issue is school reopenings. The children, as Mike said, are very, very low risk from COVID, much lower than from the flu. And it's been shown that unlike the flu, children are not spreaders, which is why all the European governments are opening their schools. Locally, though, we see a lot of resistance from unions, even school districts. So this is an area we all need to engage on in the very near term, because the damage to low-income children, to minority children, is absolutely immense when schools are not open. the children of professionals do much better, but those are not we need to focus on the whole population. So there's an enormous issue we have to deal with right now. We also have to deal with further reopening. As Mike mentioned, there's a whole range of businesses which are not, for the foreseeable future, are being told that there's no plan to reopen them. I did mention also that probably not in the immediate term, but hopefully in the near term, we need to focus on the legal aspects of challenging the overly broad health officer powers. As I mentioned, Ohio has had some success there, but the notion that we can, at the drop of a hat, be under the dictatorial control of an unelected person is very problematic given our American system of government. And finally, of course, we all need to be part of education, to educating others to overcome all the media fear-mongering, whether it's citizen forums like this, social media, because at the end of the day, the virus isn't going away. We have to learn to live with it. High-risk people need to take appropriate enhanced precautions, and all the rest of us need to get back to living, with sensible precautions, as Mike said, but we need to get back to living. So with that, I think we're moving to the Q&A, Wendy.
Yes, thank you. Very interesting discussion, you two. Love that. And Lisa and Mingy are going to be joining us also. Lisa, did you have a leadoff question that you wanted to ask?
Let's see. I didn't know you were going to call me on me first.
Oh, sorry, I thought you had piles of questions for them. Lisa's been following this very carefully.
Yeah,
She's a medical technologist. So kind of interesting. While you're looking for something, though,
yeah.
We have a mask denier, and I have to admit I'm kind of along with them. How long do you think this mask thing is going to last? Is it going to be forever? Are we going to turn into something like Asia where people have to wear a mask forever? And how about, speaking of personal responsibility, if you know that you are not sick, do you really need to wear a mask? What's your take on that, Mike?
That's a great question. Actually, I read Mark's James's comment, and I'll actually address his comment about China, because the problem with China is we really don't know what happened there because they obscured the history of the disease. And the disease was very widespread before they really knew what happened. And they were in denial until December 31st when they had 2 whistleblowers. But we now know that the disease was there as early as October from satellite data showing incredible increases in traffic in the Wuhan hotels from the very beginning of November, which means the disease had to be widespread before that. And here's my bottom line on it is, and there are a number of studies I've been looking at. There were very good papers looking at the value of masks from a wide range of things, and they're kind of impressive, but it's hard to deny the data. Why is Santa Clara different than the rest of the U.S.? Why was the countries outside of China, right next to China, that were calling the World Health Organization from December 1st, Taiwan and Thailand in particular, why have they almost no disease whatsoever today? Thailand has 0 cases today. They've been at 0 cases for a country for the last week or two. I got a friend who's an expat. He was the main earth and dams engineer for Santa Clara County, and he's been stuck in Thailand since March. And I keep asking him that question, and we go back and forth. What's different, right? I don't think mask use has to be ubiquitous, but from my standpoint, it's very easy to say, if you turn back on the economy, I'm very willing to wear a mask indoors in group situations. That's where the big risk is, right? Do you look at where masks were effective? How many people got COVID in grocery stores where you had thousands of people across the Bay Area and thousands of grocery stores? We had one grocery store with an outbreak in one part of Alameda where it was a low-income neighborhood where they just weren't wearing masks a lot in that neighborhood, and you had a widespread amount of disease. So the empirical data is pretty strong, which is correlation but not causation. But from my standpoint, I'm willing to do the mask indoors, and I think the timeliness is we'll have the disease much more under control in a matter of months. Is it 9 months or less? But something in that time. We're not going to be wearing masks 100% of the time for years and years. I can see this going on. We figure we will learn more about where the risks are and which are the worst gears peoples, and we do better tactically to manage the people with the disease, et cetera. I think that the severity of things will go down that we have to do. For me, I stopped wearing I tried wearing N95 masks when I was doing deliveries locally because it was oppressive. But when I read the papers about hey, 2 people wearing a bandana knocked down the transmission of droplets 90 to 99%. You know, it started to stick in my mind. I said, okay, it's not that uncomfortable to wear a regular surgical mask, and I wear it just in the risk situations. I'm out and about a lot, but I'm only wearing it when I'm going into the store. I see a lot of people wearing them around driving, so you don't have to wear them constantly. You probably don't have to wear them in your family, right? But if you're doing larger groups and stuff, and at our Republican meetings, we've had a mix of those, but we're outdoors, and we're specifically making the meetings outdoors because the risks are lower by 10 to 100%. So the real big risk areas, I think that's what will make a difference. A good example, and I don't want to dwell on this because I want to get to other questions. It was my sister called me when Arizona opened up, and she sent me pictures off the TV set of the bars being totally packed in Mill Avenue in Tempe and in Scottsdale. And I just got a long message back from a friend in South Carolina who said the same thing. You know, we were doing okay here, and when they opened things up, people came down to all their summer homes, and it was all the young people out in all the places, and now our numbers, they're up to 15%. A lot of the places I mentioned as hotspots are up to 50% or higher. So it seems to be correlate very well. I don't have the science down on it, but for me, it's a small trade-off. So sorry for the long answer.
It could be an irresponsible portion of the population too that are spreading all those bugs. Anyway, Lisa, go on.
Oh, okay. So I had this question too, and I see some others did. As far as, you know, we really need the schools to reopen in the fall. And I know it's been said that children are not, how do they know the children are not like spreading this, you know, as easily? That's sort of the question, because I think that's what people are, because usually kids are big spreaders of the, you know, colds and things like that.
So, you know, we can provide the links to the studies. I think the EU in Europe, they've done better work than they have, frankly, in the US, where we've mainly seen a lot of, you know, fear and panic. But they've done, you know, very careful observational studies. You know, there's been a lot of speculation because children are, you know, massive spreaders, you know, of the flu and so on. There's been an assumption that they must be for COVID, but that has actually, with observational studies of childcare centers and schools that have opened in Europe, they have found that that is actually not the case, that children do not spread to adults. You know, adults spread to each other, adults may spread to children, but children do not spread to adults. And so it was on that basis that all these European governments are very confidently reopening their schools, unlike over here where we see all this, you know, random panic. So, you know, I can send links to a couple of studies. Mike probably has them, you know, some additional ones as well, but it's been done in many countries, you know, in Iceland, in the Netherlands. There are several, I don't remember all of them off the top of my head in Australia, but there's a great deal of confidence of that because these are observational studies. You know, what happened, you know, when the schools and the childcare centers and so on were open, you know, where did the transmission happen? You know, when adults got infected, they got it from each other. So maybe Wendy, Mike, and I can send you links to these studies and you can, you know, then send it out to the people who registered. That might be the best way to handle it.
Yeah, we've also had a request for slides too. Are you willing to hand over your slides and let us post them, Mike?
Yeah, I might need to clean up 1 or 2 things on them. I do have to I'll create a PDF and give it to you.
Okay, sounds good.
Nikki,
did you have a question?
Well, one thing is someone is asking for both of their contact information. If we can post it again, that would be
I just
nice.
posted it in the chat.
Okay. Oh, great. Okay. And someone, Jane Bernie, wants to ask Mike about your understanding of use of the HEPA filters. Is that, I'm not sure.
Oh, HEPA filters.
Oh, HEPA filters?
HEPA filters?
Yeah, that's a good question because there's another line of just thought that it's been going on for months and I only recently became tied into, and actually Wendy here gave me some links to some of that where those discussions have been about one example was people were looking at where all the current hotspots are in the U.S. and saying it's all the hottest parts of the country where people are indoors and air conditioning all the time. Is air conditioning the mechanism of spreading? And there was a lot of discussion about that being true in New York. They really had a super outbreak. When you look at the U.S. statistics, with New York subtracted, it greatly changes the overall country statistics. But can you filter, can you address, I started thinking about how do you address that, and what you need in a building in an HVAC system, which is for, small to large enterprise systems, they called high volume air control systems. You actually need to substantially, because HEPA filters will filter the virus, but they're very dense. So you need a lot more force. You need a bigger blower, and you may need to change some of the ducts and some of the blades of additional blowers. So it's not a small upgrade, but it may be doable, like doing rebuilding your engine a little bit on your car, putting a different carburetor on it. But there are multiple things you can do. You can't go out and buy a HEPA filter for your home and put it in the furnace, because you won't have any air coming out of your furnace or your AC at home. You can buy a portable HEPA system that you can place in your home, just like you buy a portable air conditioner. But to date, I don't know that that's really been proven. There's correlation here, right? There's not a lot of science to it. Clearly at San Quentin, there was a lot of discussion that it's the oldest prison in California, one of the oldest in the U.S., that by bringing 21 prisoners down, and the type of air system that they have there, which is very old, was a means of spread, and the prisoners had no way to escape from it. And they still have the cases there. The prisoners are not wanting to take the test until they get very severe symptoms. So we're going to continue to see cases there for some time. But still, again, those are correlation factors. And those are the ways, there are ways to do that. I know going back to the schools, I know at least a couple of school districts were looking at, could they upgrade certain air systems? And what would it take to go to HEPA type of systems. So I think Wendy was the one that pointed out Steve Wynn did it to all his resorts in Las Vegas. Because he wants to open, even though, and Nevada actually has been, I think they've flattened a little bit. They were going up well above 10%, but I think they've come back down towards 10% from about 20%.
I was reading that New York City, that was a big deal, because those old buildings, you're breathing the same air that everybody's breathing throughout in those areas. Paulette, there was a question here about the names of the Stanford doctors, because people wanted to look them up. Can you mention the names again?
Oh yeah, I did type them into the.
Great. Okay.
But, let me just say it, because I couldn't see the answer, so I don't know what happened to them. But it's Dr. Michael Levitz. And he's a Nobel laureate, and then Dr. John Ioannidis, who's a world-renowned epidemiologist, and although he's being attacked right now because he won't, bow down to the narrative, he's actually one of the most cited epidemiologists in the world. So it's really interesting that these very, very eminent people, we're in such a politicized environment that when people are trying to actually do science the way it's supposed to be done, they get attacked, not because nobody challenges their data or their facts. They just don't like the answers.
Very true. Yeah.
Ioannidis is famous because he's such a zealot about scientific method, and he's the sixth most quoted. His papers are the sixth most quoted papers in the world, and Google does pretty exhaustive statistics on that.
Interesting. I also like Dr. Scott Atlas and Dr. Bhattacharya, the ones that are actually doing the research up there. It's kind of interesting listening to those guys. Lisa, did you find a question?
I did. So we have some questions on, therapeutics. So the like hydroxychloroquine, and do you have any more information, Mike, on some of those that are being
I have a lot of mixed information on hydroxychloroquine, and some of the studies really went after attacked it, where they were trying to make it toxic. There's a lot of reports from doctors that say hydroxychloroquine was effective. The things that are interesting to me are there are some steroids that came out of multiple sclerosis stuff that are on the leading edge that they've been trying with and have shown remarkable results. So that's later for people that are getting to if your blood ox is dropping, that would be a good one to bring them towards. If you're using that on top of getting somebody oxygen or a CPAP machine ahead of when they need to be in ICU or in a ventilator, the outcomes in those cases are I think we'll see the statistics changing dramatically. I can get information. There is a couple, in fact, Vicky Nordheim sent me one that's being used in Texas in a nebulizer that is reporting a lot of results, but there's another new one that's it has limited supply, but it seems to be very effective as well on the steroid side of things. Additionally, besides, I'm trying to think of Risperidol, which is the famous one that's going to be really, $2,000 a dose that they gave away 1 million doses on, which literally gets us a handful of doses to a couple hospitals here in the Bay Area when it comes down to it. Effective antivirals early in the cycle, people are trying different ones and finding some things may be positive. So I think you're going to see stuff. The thing is to keep tracking where people are seeing results. The interesting place is for me, if you like to go through websites and look things, is find websites where doctors are discussing what they've used and what works. And I find those very interesting. And they're not colored by the media or a given scientific study that hates Trump, that wants to take hydroxychloroquine off the market.
Yeah, because I was listening to Dennis Prager this morning, and the beginning of the show was the doctor that uses hydroxychloroquine, zinc, and zithromycin, in the after within the first 5 days of symptoms or testing positive or whatever. And he's writing an article, I think.
And I'd just like to comment on that. I come from India where malaria was endemic, and hydroxychloroquine is so widely used. Even when my husband and I went to Africa 2 years ago, it was given to us as a prophylactic. But, I come from a country where hydroxychloroquine is just used all the time. And, the scaremongering in this country around it, and I think it's very politicized, has just been amazing. It's very well understood who should not get it. But it's very widely used. Very few people fall into the category where they should not use it. So, I would say that this politicization of medicine is a really troubling thing. And it's very unfortunate. I think it's not just my opinion. Many people do feel that people have died because we politicize medicine here, and it's very unfortunate.
That is amazing. Minnie, did you have a question?
Yeah, there's a question regarding the spikes in cases. How should we look at that? Do we have to worry about young people who get mild cases and recover without issues? And how do we look at the death and hospitalization numbers? Do we want to achieve the herd immunity or not? But if we want, then that means more people has to be infected. So about all these numbers.
So we'll ultimately get to herd immunity. It may be at much lower numbers. But I'll go back to what I said earlier, which I need to get across, which is case counts are not as important as test positive rate. Test positive rate tells you snapshot what's going on in your local community, in your local epidemic. When you look at that on a 7-day average, and now you have to look a little bit longer because we've burdened the lab. The labs are getting slower again on turning around the tests because we've quadrupled the number of tests per day in Santa Clara County twice. So we're doing 16 times as many tests as we were doing 2 months ago. And you really want to look at the data that's a few days old where it's got all the tests and it's a full 7-day rolling average, but that gives you much better data than the total number of people. New cases per day, the news and media is jumping all over that. We were running 30 cases per day in early May, and now we're running 120 cases per day, but we're doing more than 4 times as many tests. Hospital capacity, you need to look at what's the overall capacity. And what the media is reporting, unfortunately, is what's the percent increase in hospitalizations. If we went from 2% to 3% and 4%, and it's been in the news since June 23rd here in Santa Clara County. We're still a very healthy range of hospital capacity here. So, and overall, the area under the curves in terms of the death rate of per infected is actually coming down. And it's coming down for a lot of reasons. We know not to send COVID positive people to a nursing home, we need to take them out of the nursing home and get them care, right? We can probably make changes in how agricultural workers are performing their duties and protect them better, right? Or how they're living in close quarters. Are there things that we can do to lower the rates there? I think there's a lot of things that are practical that you can address where the risks are, where the outbreaks are. I think the biggest thing in the areas of the U.S. where the spikes have happened is you're going to have to use stronger measures. You're going to have higher compliance on masks as a beginning, and they may need stronger methods in an area like Phoenix where the tested positive rate is over 30%, which we haven't seen anywhere in the U.S. since the early stages of New York. Tested positive rate originally, when you look at all the counties here in the Bay Area, started in the 20s to 40% and we dropped very quickly. But we haven't come back to anything near that. We're in a healthy range throughout the Bay Area outside of a couple little outbreaks.
Well, is the Mexican border open now where people are coming into Texas and Arizona and California?
Well, what I've been reading about that, many sources, I would say they're reliable, is that although the border as such is only open for essential, for trade and commerce, the infections in the border counties are being driven by Americans, permanent residents and citizens who are coming back in from Mexico for treatment.
Oh.
So, and that's why you see this huge preponderance. I mean, Imperial County is talked about a lot, but of course our wonderful newspapers never say those are people coming in from Mexico, which has a huge outbreak and cannot treat people. And Imperial County is a small population county. They don't have many hospital beds. So when they say, they're overwhelmed, yes, but it's a small county. Our state is not overwhelmed. Less than 10% of our hospital beds are currently occupied by COVID patients. So, and that is the problem with the media fear-mongering, isolated small counties with very few hospital beds, if they have agricultural workers, or in this case of Mexico, people coming back across the border, that is not indicative of a reason for all of us to be alarmed about things. Flattening the curve was making sure our hospitals don't get overwhelmed. And as of today, I just checked this morning, we're at about 10% of our total California hospital beds are occupied by COVID patients. So, that the media has no perspective. Unfortunately, even when we listen to Newsom or Sarah or whatever, they tend to talk of these alarmist, hey, we've gone up 50%. Yeah, we went up from 20 to 30. When you have 1,000 hospital beds, that is not cause for alarm. But there's a very, I would say, irresponsible messaging happening at all levels.
Yeah, and I think one of the issues, South America is having different versions of different epidemics. And one of the issues I have with Mexico is Mexico's not being very honest about where there are outbreaks or not. But I suspect that some of the increased numbers across a lot of Southern California, even in the urban areas, that's where the people are that go down to Rocky Point. It's a huge summer travel destination for people there locally, and it's still allowed. So even though we're under lockdown, they can go down to Mexico and go out and hang out. And I suspect that it contributed not just to Imperial County, which is pretty rural, but the urban areas such as Orange and San Diego and LA and as well, right? Even all the way up to around further north, where a lot of people in that part of the country like to go to Mexico a lot because it's close and it's nice.
Well, this has certainly been, go ahead, Paulette.
No, I just want to say, when we look at who's testing positive, I agree with my case counts are not so much the issue, but even when we look at the tested positive rate, I mean, the demographics of who's testing positive have changed very dramatically. So there again, hospitalizations are the metric to watch, because when a 20-year-old gets it, even if, 20-year-olds are by definition often irresponsible, but if a 20-year-old gets it, that's not a cause for alarm, because, the mortality rate for a 20-year-old getting COVID, or even the hospitalization rate, is incredibly low. I think John Ioannidis sort of summarizes and said, if you're under 45, your chances of dying from COVID, I think he said this recently, I can pull up and send the quote from somewhere, but your chance of dying from COVID are practically zero. That's the phrase he used, practically zero. It's very different for different age groups. As Mike said, a lot depends on these severe comorbidities, but they've far less frequent in lower age groups. So this whole notion of understanding what your risk is, and not just our risk, but understanding the data that's being flung at us and what's being thrown at us is very alarmist, context-free, information. We really have to know the facts, that if it's, for instance, in Santa Clara County, 2 weeks ago, the median age for testing positive had dropped to 35, whereas it used to
significantly.
Right? And
It's
so,
dropped significantly across the Bay Area.
correct. And so, people in that age group, it doesn't matter if they test positive in a sense. I mean, I'm not being callous when I say it doesn't really matter, because they are not really at risk. I mean, my daughters are both in their 30s, and they're back at work, they're in essential professions, and they're back at work, they can't work from home. And I'm not worried about them. I hope they don't get it, but I'm not sitting and panicking about them, because if you know the data, then you understand, when you should worry and when you shouldn't. And I think that's something that's been completely lost. Our county, whether it's our health officers, does not communicate that way. Our governor does not communicate that way, and the media is not communicating that way. And it's a real disservice.
Yeah, if I look at how Jeff Smith starts each update, right? He starts out with all the things that are bad, and he talks about us in the same context he talks about LA, which are night and day in terms of where we are with the epidemic here today. But you would say, why wouldn't you say, look, we have much more lower age people are where our tested positives are. That means we're going to have better health outcomes. It's never mentioned. Paulette just mentioned, and it's kind of the question earlier about what's important. Those are lagging indicators, but the value of tested positive at this point isn't to decide, are we going to lock down or not? It's the value of it is recognizing where there are other problem spots we need to do a little tactical focus on. Agricultural workers are obvious. Testing people in the workplace, as we've done, the guy, Marty Fensterscheib, has done a great job for the County of Santa Clara of taking tests to where people are most at risk, and they're doing work groups where they're going after large employers, whether it's manufacturing, meatpacking, et cetera, where there's risk. And when you start to see tested positives, respond to it. We briefly shut down a few construction sites in Mountain View a few weeks ago because we started seeing little clusters. That's a way you're going to manage the manifestation of the local pockets of the disease without shutting down 100% of the economy.
Exactly. I mean, I was just recently, I spent the weekend, spent most of the week in Monterey County. We just wanted to get away. Well, they have this increase, but it's among the agricultural workers. And yet they foolishly, closed down indoor dining in all the tourist areas. I mean, these are the sorts of senseless, responses as opposed to data-driven responses. We keep being told they're going to be driven by the data and the science, but that's not what we see. We see, it used to be at the state level, now it's at the county level. Instead of focusing on where are the problems and being targeted, we're in this mode of the whole county is one thing, which it is not, and we get these blanket orders. It is very damaging. It's very destructive, and as I said at the beginning, it's hurting the poor. Service workers are being hammered. Low-income people are being hammered because it's their jobs and livelihoods that are being crushed.
So to follow up on Paulette's comments really quickly about Monterey, and thinking about what do we need to focus on, what do we need to do moving forward, it brings us back to now we're being constrained by the state again, because it was the state that came down to Monterey and said, your statistics don't match. You're on the watch list. And 3 days later, they had to shut down outdoor dining where it's been fine for months, right? They opened in the beginning of May. They had personal services. You can go there and get a haircut. The state is also constrained again. We've got to get the state to change their metrics for making the decisions. And we've got to push on the counties to focus on the tactical stuff, stop locking up all our business people.
Right.
It is what I think, seriously, it's a plandemic. Seriously. And I suspect, not to be cynical, but there's going to be 119 more days of this, and then it's going to disappear. As soon as we hit November 4th, I think Stephen Thayer said that too. And what worries me, Jackie, just to put a closing comment in here, is correct. What are going to be the psychological impacts to kids that either have to be homeschooled or are going to be sent in all of this biohazardous gear? And like I was saying yesterday, I had 3 young sons. There is no way they would wear a mask all day long at school. They would be the bad kids, the evil kids that would be sent to the principal all the time. It's just going to be a mess. But Jackie, we had talked about, should we talk about what's going to go on with kids going to school? But we decided that is another whole nightmare to be dealt with. So you may hear something in the future about that. And it looks like our president has returned. And I'd like to thank you very much.
Fascinating discussion here. And but we are at 11:08, and we promise everybody will be done by 11. So you have the contact information for Paulette and Mike. Hey, this was a fascinating discussion, and it seems like we should have perhaps a follow-up at some other time as things progress. But thank you so much, Paulette, and thank you so much, Mike, and we appreciate all of you.
Thank you, Jen.
It's been a great meeting.
Yeah, thank you.
And we'll see you on the 22nd, right, Jan?
See everybody on the 22nd with attorney Mike
Timothy Snowball.
Snowball. And is this
How
lockdown?
many civil liberties have we given up?
Yes.
What can we
and
do about it? That'll be an interesting discussion.
how we easily give up our civil liberties. This is what is scaring me. I mean, we just, as Republicans, lay down and die. I'm astounded, actually. So goodbye, everybody. We'll see you back.
See you next time. Thank you so much.
Thank you.
Bye-bye.
Thank you.